So good afternoon, everyone. Again, my name is Ellen Barra. I'm a specialist with our Provider Outreach and Education Department. On the call with me today is Leanne Foster, my friend and colleague, who's going to be watching our chat for us. As we uh, as we normally talk about when we are doing our presentations, you will have several opportunities to take a survey following this presentation. For those of you that are listening through our encore presentation, you also will have an opportunity to take a survey. This will be a card at the end of the encore presentation, and there will also be a link within the description of that YouTube video. For those of you on the live call today, we will provide that link for you at the end of the presentation. So what we're going to talk about today are evaluation and management services and choosing your level of service based on time. And this really is a question and answer presentation today. So I'm going to be going through some information very briefly, and then we want to open it up for your questions. So the next slide that we have is a disclaimer slide. The information that we're providing you here today is as accurate as we can make it as of today. However, if you've been with Medicare for any length of time, you know that Medicare rules do change often. The final rules and regulations by CMS all are the final determinants of coverage. We will provide responses to your questions based on how you ask the question. But again, Medicare rules determine final coverage. And then CMS does prohibit recording of the presentation for profit-making purposes. If you're recording, if you're doing screenshots, we would ask that you stop. Again, we will have this available both on our website under the Encore presentations and our YouTube channel as an Encore presentation, probably within the next 2 weeks. The next thing that we have is just the CPT copyright notice. We do have CPT codes listed in the presentation today. Medicare does not own those. Those are owned, both the codes and the descriptions, by the American Medical Association. By remaining on the call today, on the webinar today, it just means that you understand that the American Medical Association owns those. So we're going to provide a brief overview on using time to choose your level of service. And then we want to provide time for your questions. And we have some pre-submitted questions that are kind of interspersed throughout the presentation today. Time is one of the 2 ways that you can choose your level of service for an evaluation and management. Medical decision making is the other way, but that's a different presentation. We have just a couple of acronyms listed here for you. Medicare and dealing with anything with Medicare really kind of turns into an alphabet soup. So we've gathered them up in one spot for you. The next thing that we just want to bring up is a reminder about medical necessity. Evaluation and management services must be reasonable and necessary in order for Medicare to make payment. The services have to be either evaluating, treating an illness or injury, or to improve the functioning of a malformed body member. So this is all based on your documentation. Why is the patient there? What are you doing for the patient? What is the medical reason that the patient needs your specific services for this date? When our medical review contractors, our internal medical review staff, comprehensive error rate testing program, etc., that's the very first thing that they're going to be looking for. What is the reason and the medical requirement for this encounter for today? Now, when using time, determining the procedure code is really pretty straightforward based on your documentation supporting the time that you have spent. You want to verify and really work with your practitioners to make sure that they're capturing all of that time. When you're using time, you can use both face-to-face and non-face-to-face time spent working directly for that patient on that date of service. Don't leave money on the table. Make sure your practitioners are capturing that non-face-to-face time. So this is just a reminder for you, again, that the American Medical Association owns the descriptions and the procedure codes. And as you can see here, they have made some very drastic changes over the last couple of years. In January of 2021, they made changes for the definitions and how you choose your level of service for office or other outpatient services. And then in January of 2023, they made those same changes to the rest of the categories. Now, you can choose your level of service normally based on either time or medical decision making. There are, however, two exceptions. For an emergency department, you can only choose based on medical decision making. And for critical care, you only choose based on time. There are multiple levels of service, and you want to be looking at those descriptions of the procedure codes themselves to determine where your time fits into the different levels of service. And then, of course, you must meet or exceed the time that is listed within that code description. The time that you spend is on the same calendar date by that practitioner. And again, this can include both face-to-face, non-face-to-face time. When documenting, you need to document the specific time, not a range. What we're seeing in a lot of the documentation coming back is that it is repeating the range for a particular procedure code. And that really isn't your best practice. What you want your physicians and practitioners to get in the habit of doing is to really document that time that they have spent and the activities that they have spent that time on. Now, when we're talking activities, that's mainly going to be your non-face-to-face time. Now, you don't need to really stopwatch yourself, but the time spent does need to be within the medical record. One of the things that the Medicare contractors and the medical review contractors will look at is really the accuracy of that time. So how do we do that? Obviously, we're not there, when the service is actually happening. We're evaluating that documentation. So what we're going to be looking for within the documentation is that the information contained in the medical record really looks like it supports that time. So for an example, if you have a practitioner who documents, they spent 80 minutes with the patient, but the only documentation that we have is the patient has a cold. I told them to go home and take 2 aspirin and call me in the morning. Well, those two things are not going to match then, are they? The documentation that's provided within that medical record is not going to support that 80 minutes worth of time. So when you're evaluating your documentation and you're doing your internal audits, that's one of the things that you want to be looking for. The time is by the practitioner. So your ancillary staff, your nursing staff, their time is not counted in order to choose your level of service. One of the pre-submitted questions that we had has to do with signing the documentation. And the question was, do you have to sign the documentation on the same date in order to be able to count time? And the answer to that is no. If you're dictating and that kind of stuff today, and your physician and practitioner is not signing until tomorrow, while they can't count the time from tomorrow, they still can count the time that they spent for that patient today. What about a split shared service? Well, you count the time that both practitioners are providing for that patient or spending on that patient. Again, doing face-to-face and non-face-to-face care. And then, of course, you'll bill under the practitioner who provided the substantive portion of that service. Well, what about incident to services? Well, if you're providing and your clinical staff and your ancillary staff are assisting you in providing that service, their time is not counted. It's only the time by that practitioner. If your service is provided by a non-physician practitioner under the Incident to guidelines, then you can count their time and you want them to document that time. So here are some of the things that are the non-face-to-face time that you can use when you're choosing your level of service. You can see they're preparing to see the patient. If your physician or practitioner spends 5 minutes, 10 minutes, whatever, on that data service, taking a look at past testing that has been done, looking at the results of that testing, etc., that time counts. So, make sure your physician is documenting that. One of the pre-submitted questions that we have and we receive quite often is, well, my physician reviews all of the charts and everything today for the patients that he's going to see tomorrow. Can we count that time? And the answer to that is no. When you're looking at choosing your level of service based on time, it's only time spent on that calendar date of the encounter itself. Now look at that next bullet point, obtaining or reviewing separately obtained history. So you see the patient and you need to contact the patient's daughter, or you need to contact the nursing facility where the patient is at, because the history coming from the patient maybe is not as accurate as you need it to be. So if you make that telephone call to that daughter and you spend 15 minutes gathering history from that daughter, document that. Count that when you're choosing your level of service. Another thing that is part of this is your documentation. When you're documenting this, when you're dictating your notes, when you're typing this into the file yourselves, again, it's only practitioner time, you can count that time also. So you can see here some other items documenting the information in the medical record is listed here. And then the other three, you'll notice that they say when not separately reported. So if you're doing care coordination, like chronic care management, and part of your activities happen on that date, that time is going to be part of the chronic care management service, not part of your E&M. Referring and communicating with other healthcare professionals. There are procedure codes and they're called interprofessional consultations. If you're reporting that, then you don't count the time that you spent with that other practitioner. And then independently interpreting results. If you're doing a report on the chest x-ray that you ordered, then you would not count that time as part of choosing your level of service if you're also billing for the professional component of that chest x-ray. Now you'll notice on here you don't count, things that are separately reported. You don't count travel time. And then for teaching physicians, you would not count time that is teaching in general and is not specific to that individual patient. So the next slide that we have there for you is just pictures of 3 examples of procedure codes. And it shows you what the time is for each of those. So for an example, the 99202, 15 minutes must be met or exceeded in order to bill for that procedure code. If you have 13 minutes, then you can't bill for that procedure code. And then for your upper time limits, as your time keeps growing, then you want to look for those next procedure codes. Separately reported services. We kind of talked about that a little bit, but look at the example that we have up here. The documentation that we received showed 47 minutes, and the documentation shows both the procedure and the E&M. Well, we can't determine from that documentation alone how much time was spent on that separately reported procedure and how much time was spent on the evaluation and management service. Another thing that we get quite often is kind of like an attestation statement almost, and it will say something to the effect of time spent was 27 minutes, exclusive of time spent on the procedure. That's really not your best choice. The best choice is really to identify, I spent this amount on the procedure, I spent this amount on the separately reported evaluation and management service. Um, the best thing to do is really to break it down into what it is that you're doing on that date of service. So what then is Medicare going to expect? Well, we want that documentation to be an accurate reflection of what your physician or practitioner did on that date. Um, Documentation that states the time includes ordering testing, but the documentation doesn't really indicate that any tests were ordered. We're not going to really look at that very favorably. Let me put it that way. We're going to have questions on this. Another example is the standardized language. Like we talked about previously, one of the E&M procedure codes, their time description says 30 to 44 minutes. And so one provider we've just recently reviewed, every one of his documentation said I spent between 30 to 44 minutes. Well, that's really not accurate. Um, you want to have your physicians and practitioners be accurate in the time that they're spending on that particular patient. And again, if you look at that last bullet point, we will be looking at the activities documented and really kind of making a determination as to whether that makes sense based on the documentation. Now, the next thing that we have up here for you talks about the prolonged care codes. So we've got the first code listed, the G2211, or I'm sorry, G2212. In order to bill for this procedure code, number one, you have to have chosen your level of service based on time. If you're choosing your level of service based on medical decision making, you do not ever use this procedure code. It's only based on time. And then you have to meet a full 15 minutes in order to bill this. So what the picture that we have here on the slide for you is number one, you have to meet the highest level for either initial or subsequent patients. And then you have to have that full 15 minutes. So that first example there, the 99205, shows 60 to 74 minutes. In order to build that G2212, you have to have at least 89 minutes in order to do that. And you can see it's the 89 through 103 minutes. We're aware that CPT has changed the description on some of the procedure codes for 2024. CMS, however, has not yet updated their charts. So this is the timeframes that we would be looking at for this particular code. We also have prolonged care services for inpatient. Again, your initial and your subsequent, you have to have that highest level of service. You have to exceed that by 15 minutes or more, and then you can see the procedure code listed there for you. Nursing facility services work the same way. Only I want you, wait a minute, I want to go back a minute because I missed something. At the bottom of this picture, you can see same day admit and discharge. This is on the date of the visit to 3 days following the visit. Now, let me explain to you how that one works. Your time for your procedure code is only on the date of service. The time for your prolonged care code, when you're using that 99236, you can have that prolonged care time on the date of the service or within 3 days following that date of service. So this could be time to do your discharge summary, things along that nature for that patient. Prolonged care services for nursing homes. Again, you can see the procedure codes and the time. You'll notice here this is 1 day before the date of service and then 3 days after. So again, on the date of service, you have to meet the 99306 for an example. But within that 1 day before up to 3 days after, you can document additional time for that prolonged care service. And then we have the listing for you for the home services. The procedure code, the G0318, and you'll notice on here that it's 3 days before the date of service and then 7 days after in order to bill for the prolonged care service. And then what we have for you here is additional time information. For your critical care time, you have to have at least 30 minutes in order to even start looking at that code. If you have less than 30, then you're going to bill an initial or subsequent visit procedure code. So the 99291 is the first 30 to 74. The 99292 is each additional full 30 minutes. So if you had 85 minutes, you would still only have the 99291 that you would be able to bill. You have to meet that 104 minutes in order to get to the 99292. And then the discharge management codes are listed there for you. The 238, which is the inpatient, and the 315, which is nursing facility. The first 30 minutes go with those procedure codes. If you have more than 30 minutes, then you can move to the 99239 or the 99316. The use of the 99239 is a big area where our medical review staff are down coding to a 99238. There's no documentation that's been submitted showing the time. Really, for both of the procedure codes, you need to be documenting time. But if there's no time documented, we can't support the 239 or the 316, and therefore Medicare will have to download that. So again, you don't want to leave money on the table. You want to make sure your physicians and practitioners are documenting the time that they're spending. The next thing that we have for you is just some resources. We've got the AMA information there, the Medicare Claims Processing Manual, Chapter 12, Section 30.6 is really kind of the Bible on evaluation and management services. And then we've got a link for you to the CMS Evaluation and Management Service Guide. So before we open it up for questions, we do have some pre-submitted questions I want to go through. One of the questions says, our electronic medical record has a time calculator for outpatient visits. Can we use this, or do we really need to document time? Well, you really need to document time. Your electronic medical record time calculator could be simply looking at when your physician is actually in that patient's chart, which means that it could be losing some of the non-face-to-face activities that your physician is doing. And then the other thing, think about it for a minute. If you go into a car place in order to get your car repaired, they have calculators and they say if you're going to repair or replace a water pump, here's how long it should take. Well, sometimes it doesn't take that long, and sometimes it takes longer than that. So you want to be accurate within your documentation. Another pre-submitted question has to do with appeal rights. If Medicare downcodes a service because they don't agree, do you have appeal rights? And the answers to that is yes. What you want to do when you're resubmitting that appeal, though, is you want to point us to where the time is documented. You want to show us my physician documented 45 minutes, or they documented 27 minutes, or whatever the case might be. Another question that we receive is, can you count time spent with the family without the patient present? That one gets a little tricky because if you're calling the daughter to get history on the same date as the encounter, then yes, you can, because that's work that you're doing for that patient. If you're calling the daughter to say, here's what's going on with mom, that's not a service to the patient, that's a service to the family member. So you would not count that time. Now, if the patient was present and you're providing that information back, that's giving that information to both the patient and the family. Face to face with the patient, you can count that. Another question that we get is, well, when I'm using time, I have a 99204 level service. When I'm using medical decision making, I have a 99203 level service. What do I do in that situation? As long as your time documents that 99204 and you have medical necessity, use whichever one, either time or medical decision making, whichever one is more advantageous to you, as long as your documentation supports. Another pre-submitted question that we had, the patient initiated a call on Monday, and then the patient came into the office on Wednesday. This was a previously scheduled appointment. Can we count that time that we spent on Monday? And the answer to that is no. Again, time is only on the calendar date of that encounter. So the physician, and this is another pre-submitted question, the physician documents I spent 50 minutes on almost all of his procedure code 99204. How would Medicare evaluate that? Well, if we're looking at that particular provider and we request documentation for the 99204 and 90% of the documentation says I spent 50 minutes, Medicare is going to question that. Again, your encounters with your patients are going to be dependent on that patient, on what is happening with that patient, what your physician and practitioner needs to do. It's not all going to be the same time. That's why we really encourage you to stay away from statements that say, I spent 30 to 44, or the calculators within your electronic medical records, etc. So, Leanne, we'll go ahead and see what questions we have in the chat.
All right, Ellen, we do have several, and I will start with a question from Julie. When billing on time, can you include the time spent in filling out FMLA or disability paperwork if it occurs on the same date of the patient office visit?
Well, let's go back to, I'm going to flip back over here real quick. Medicare says that you do not count performance of other services separately reported, travel time, or teaching that is not specific to that patient. So if you're there with that patient and that's part of the reason why that encounter is there, and you're completing that FMLA, yes, you can count that time. Next question.
All right. Next question is, did I understand that ancillary staff time can be counted in provider time? Other organizations have said that ancillary staff time is also excluded from provider time.
When you're using time, it's only your practitioner time. Only your physician or your nurse practitioner or physician assistant, etc. It is not your ancillary time. It is not your nursing staff time. So only the practitioners themselves.
All right. Next question is, if a physician sees a hospital patient, E&M, and performs discharge management on the same day, can those times be combined?
No, your Medicare pays for evaluation and management services on a per diem basis. If the service that you're providing to that patient is discharge management, then that's the procedure code that you're going to submit. If you have, you can have where you see the patient and then you discharge them. You could have situations where you see the patient and provide an E&M and then they die, and you're going to do the discharge management service for that pronouncement of death. You're only going to bill one of those, not both of those situations. And the time that you spent in the regular evaluation and management service would not count toward the time that you spent on your discharge management, nor vice versa. Good question, though.
All right, moving on to the next question. If there is a procedure done at the time of the office visit, like an IUD insertion or ultrasound, does the time spent on the procedure need to be documented as carved out of the total time of the visit?
That's your best practice, because then we know for sure that your physician spent X amount of time on your evaluation and management, and here's how much time they spent on that procedure. Then there's really no guesswork by our medical reviewers on, exactly how long should this have taken, that type of situation. It's better to carve it out and to show both times.
Okay. Next question, is it required to document the activities along with the total time, or is it acceptable to just document total time?
Your best practice again is going to be documenting those activities, especially when you're talking about those non-face-to-face activities. So, I gave you the example earlier of 80 minutes was documented, but the documentation simply shows that the patient came in for a cold. Okay, however, depending on your patient's condition and what's going on, your physician or practitioner may have had to make several phone calls to other people who are also taking care of that patient to coordinate that care. So your best practice is to document the activities and then the time that was spent.
Okay. Next, give me 1 second. I gotta scroll. There we go. If only one provider documents time on a split shared visit, do you use time and bill only under that provider, or do you use time and leave it as split shared?
Well, you're going to submit it as a split shared because it was. So you're going to use that FS modifier on that. When you're looking at choosing your level of service, though, if only one practitioner has documented time, then you can use that practitioner's time in order to choose your level of service. You can also look to the documentation from your other practitioner under the medical decision making to see which one is more advantageous. And then that will determine under who you bill. Now, where this really kind of shows its head more than anything else is in critical care. And so you can only submit what is supported by the time under that practitioner who documented the time.
And the next question is related to that, but I believe you answered it. They're asking if you can repeat the time requirement for critical care 99292.
For 99292, you have to have, let me get back to that slide. You have to have a full 30 minutes. So in the example, and this is back on slide 21 actually, but the first 30 to 74 minutes is the 99291 procedure code. And so you have to get to 104 minutes before you can bill the 99292. And so, if you had 104 minutes, you'd build the 99291, the 99292. In order to bill another unit of the 99292, you would have to have an additional full 30 minutes in order to do that. So if your practitioner had an additional 15, you would not bill that second unit of the 99292.
Okay, next question. Again, critical care. So for critical care reporting on the facility side, can you bill for critical care when the time is documented by the ancillary staff only, whether this is for the service or on behalf of the provider? So for this example, they're saying there is no critical care time documented by the provider.
This is not a question that I can answer for you. Leanne's going to put an email box in the chat because this presentation today is not dealing with the facility charges that are coming in on the UB04 form or the 837I. It is geared toward the professional charges. So if the question was dealing with a professional charge where the ancillary staff documented their time, that would not be part of the critical care time for that physician or practitioner. But if you're talking about billing for the facility itself, submit that question in when I show you that email box, and then we'll get an answer back to you.
All right, next question is if we have a split shared discharge service where the APP has documented greater than 30 minutes and the physician has not documented time, can the service be billed under the physician as 99239, or do we need to bill under the APP since they documented the time?
You would have to bill under your non-physician practitioner because the discharge management service is a time-based service. If your physician has not documented any time, then you bill under your NPP.
All right, next question. When the provider documents time, can you still choose to level the service based on medical decision making? When Medicare does the review, when looking at the documentation, will they down code to the time documented if the MDM supports a higher level?
No, and it's absolutely not. This is what we were talking about earlier. Get your physicians and practitioners in a place where they're documenting both, and then you choose whichever one is more advantageous. If your time supports a 99205, for an example, but your MDM only supports a 99203, bill the 99205. You have documentation to support that. If it's the other way, your time only supports the 203, but your medical decision making supports the higher level code, bill the higher level code. As long as your documentation supports what you're submitting into us, then that's acceptable to us. Don't leave money on the table. If you can support the procedure code using either one of those methods, then support that procedure code and submit it.
All right. Next, the question is if injections are performed by the physician, is time counted?
Read that one again. I'm sorry, Leanne.
Yeah, no worries. If injections are performed by the physician, is time counted?
No, and because there are different procedure codes for the actual injection service. So if your physician is doing an IM, for an example, there is a procedure code that reflects that time and reflects that particular service. If they're doing an injection into the joint, there's a procedure code for that. That one is a surgical procedure code. Um, and then, of course, you'll also have to be looking at the National Correct Coding Initiative rules and the global surgery rules if you're doing both of those services on the same day.
All right, Ellen, we have just a couple more questions in the chat. The next one is, I have a provider that puts, and this is a quote, I spent over 50 minutes reviewing patients' medical history, chart, labs, and face-to-face time on every single office visit. Is this statement acceptable to bill based on time?
If it was me, okay, if I was the biller for that particular physician or practitioner, I would be going back to them and telling them that Medicare says that's not your best practice. You need to identify time. If we pulled this provider's claims, as part of a medical review, and we saw that statement on all of them, we would question that. We would take a deeper look at the documentation to make sure that we believe that it supported that amount of time. When you're using time, it is the time that your physician or practitioner has spent working on and for that patient on that calendar day. All of your patients are not going to take the same amount of time. And so allowing without further education to your physicians and practitioners, allowing them to continue that really is going to harm them in the long run. So go back to them, provide them with the education. They need to be documenting accurately the time that they spent on that patient.
All right, couple more. What if you have 84 minutes in critical care?
Okay, if you have 84 minutes in critical care, you can only bill the 99291 procedure code. In order to get to the 99292, you have to have at least 104 minutes. And because you've only got 84, you only bill the one procedure code, the 99291.
All right, and last question we currently have in the chat. If we have a surgical outpatient for a discharge service and the nurse practitioner says I spent over 60, would we revert back to the outpatient code since there's no discharge for surgical outpatients?
Okay, Leanne, is this one happen to come from the same person who asked us the facility
I'm
chart?
looking at that right
Okay.
now. One
Okay,
moment,
or if
please.
whoever asked that question could let us know if you're talking about facility or professional billing.
And Ellen, it's not coming from the same person.
Okay, all right, so we'll take that this is professional billing. And so from what I'm understanding of the question, and if I'm not getting the question right, put it back in the chat. But so from what I'm understanding, the patient is in an outpatient setting. So they're not in a hospital, they're not in observation care, they're not in a skilled nursing facility. They're simply in an outpatient setting, and the practitioner is going over this is what you need to do next. And no, that would not be a discharge management service. That would simply be an evaluation and management service. So what you would do in that in choosing time, you'll simply look at how much time you have spent, look at whether or not you can include one of those prolonged care codes. So based on the question, it would be an office or other outpatient procedure code, and then the possibility, depending on your time, and how that's documented, of that G2212 procedure code.
And Ellen, the individual just confirmed that it was in a professional setting.
Okay.
And that's the last question we have in chat.
Okay. All right, wonderful. Thank you guys for those great questions. And again, the facility question, if you want to send that into us, we'll see if we can provide a response to you on that. So on behalf of Leanne and myself, we just want to thank you very much for spending the time with us this afternoon. Again, we do encourage you to take the survey. If you're listening to this presentation through the Encore, that link to the survey is within the description of the video. So thank you again so much for attending, and this concludes our presentation. You can now disconnect. Have a fantastic day.